Welcome to the Cambridge Neuroscience Interdisciplinary Seminar Series. This series features current work from across the schools and departments of the University of Cambridge, reflecting the pioneering work and diverse interests of members of Cambridge Neuroscience. Cambridge Neuroscience is currently going through quite a detailed consultation process to develop 6 new themes for the research we do here. Each of the next 12 talks will come from one of the 6 new themes, 2 from each. For more info on the themes and the talks covered in this series, please follow the links below and follow us on Twitter at CamNeuro. So today we are delighted to welcome Dr. Lucy Cheke from the Department of Psychology. Lucy is going to talk to us on the very timely COVID and cognition subject. Lucy is the head of the Cognition and Motivated Behaviour Lab, and her research explores various aspects of learning and memory, and in the past few years she has focused particularly on the association between memory and obesity. So we're delighted to welcome Lucy today. Take it over.
Hello, thank you for that, Devola. So I'm going to talk today about the first kind of wave of results from a study we've been doing over the last 6 months or so. And I'll preface this with a bit of a health warning that this was most of this was still in SPSS yesterday. So if it's a bit rough and ready, I apologize. I've been editing slides right up until the line. Okay, so I think it's safe to say we all know about COVID now. And mostly this is known to be a kind of a respiratory illness that is associated with fever, coughs, loss of sense of taste and smell. But why COVID and cognition? What's the link there? Well, there's a number of reasons to think that COVID may be associated with cognitive issues. The first is that there is evidence of elements that would be predictive of cognitive issues, particularly as we understand COVID more and more, we're seeing increased reports of neurological symptoms. And there's also a lot of potential mechanisms via which the brain could be injured during COVID infection, particularly including hypoxia, viral invasion of the central nervous system, and a dysfunctional immune or clotting response. So COVID-19, as we know, can present with a vast range of severities and presentations. These can range from totally asymptomatic to requiring ventilation and, of course, even death. We now know that around 35% of patients report neurological symptoms, such as headache, dizziness, myalgia, and loss of taste and smell being a big one. And this is even higher in severe illness. So neurological symptoms can be seen in up to 85% of really severely ill patients. Alteration of taste and smell is the most common neurological symptom, and it's often the first clinical symptom and often persists beyond all the other symptoms. And by some reports, up to 80% of patients have that symptom. So we can see neurological symptoms across the spectrum, and they're very, very common in COVID infection. So there's been a lot of discussion in the literature about in what way and how COVID would affect the central nervous system and the brain. And there's a number of realistic potential mechanisms. These particularly include hypoxia, clotting and vascular issues, but there is debate as to whether or not COVID can attack the brain directly. So there's some evidence now to suggest that perhaps via the olfactory nerve, COVID can get actually into the brain, causing direct virus-related encephalopathies. And actually, there are some reasons to believe that the loss of taste and smell may be indicative of COVID within the olfactory nerve. But again, this is a huge debate. Even if COVID cannot affect the brain directly, however, there's a bunch of different mechanisms that you'd expect to be related to neurological issues, particularly severe hypoxia from respiratory failure or distress. So those people that have been really finding it hard to breathe, that has a knock-on impact on the brain. There's also a lot of evidence now of disrupted blood coagulation. And this is associated with risk both of clotting in the brain, leading to strokes and ischemic attacks, but also the other end of the spectrum, bleeding and hemorrhage within the brain. There's also a lot of reports of a dysfunctional or excessive immune response to COVID. This can be in the form of excessive cytokine release, so-called cytokine storm, which can cause an encephalopathy, but also immune-mediated peripheral neuropathy like Guillain-Barré syndrome, which is characterized by autoimmune attack on nerve cells and can lead to things like limb weakness and loss of tendon reflexes. In general, inflammation is known to be impactful on cognition. So there's a lot of evidence kind of before COVID, if you like, that chronic inflammation has a significant negative effect on cognition and particularly attacks the hippocampus. Chronic inflammation provides a really toxic environment for new neurons. So neurogenesis, which happens primarily in the hippocampus, is very much affected by ongoing neuroinflammation. Potentially via affecting BDNF and other neurotrophic factors. Inflammatory cytokines have been repeatedly linked with cognitive impairments and particularly memory impairments, mostly in the rodent literature, although there is some evidence of that in the human literature as well. In the human literature, particularly, chronic inflammation is linked with the development of neurodegenerative and Alzheimer's disease, suggesting that it's not just the kind of direct immediate impact of the inflammation that may be the issue, but that if this severe inflammation carries on for a very long time, you get an acceleration of degenerative decline. Okay, so I've just given you loads of reasons to think that there might be neuro issues in COVID. Do we have any evidence that there is neural damage in COVID? Well, there is. So there aren't that many studies, but there are some. And these studies suggest that what we see is quite widespread evidence for grey matter abnormality within COVID patients, particularly in ICU patients, because those are the ones that have been studied. Particularly orbital frontal abnormalities have been found, ischemic lesions and evidence of general neuroinflammation. One interesting finding was that of those patients that were admitted or referred because of seizure-like symptoms, 89% showed abnormal EEG activity, mostly within the frontal lobes. There's also quite a lot of evidence indicating temporal lobe abnormalities, both in the medial temporal lobe and hippocampus in one study, and that was in a study where SARS-CoV-2 was actually detected in the cerebrospinal fluid, so suggested it was a direct viral effect, but also lesions indicating hemorrhage throughout the temporal lobes and some other regions. So if we have these multiple potential mechanisms of deficit and damage to the neural systems, what cognitive symptoms or what cognitive impacts might we expect to see? There's a really lovely paper by, I've never said this out loud, Bougakov et al. That really went through in detail the potential mechanisms of damage to the central nervous system and what you might see in terms of cognitive deficits, depending on what type of damage you've got. So obviously you've got a sort of anoxic or hypoxic toxic encephalopathy. And here you might be seeing maybe sort of mild attentional memory impairments, or, if the damage is much more severe, ranging right up to kind of severe sort of dementia-like cognitive decline. Other sorts of damage, such as viral encephalopathy or ischemic or hemorrhagic damage, would really be quite focal depending on where it is. So you might expect to see quite a specific deficit depending on where that damage has occurred. And there may be some reason to believe from the previous evidence that we might expect there to be certain regions of the brain that might be more vulnerable, particularly the hippocampus and the frontal lobes. But it may be that that would be something that might be different depending on the nature of the illness in the patient. Okay, so we've briefly gone through evidence of what's going on in the brain of COVID patients. But do we have any actual evidence of cognitive dysfunction? Well, one of the main sources for thinking there may be cognitive impairments following COVID is data from the long COVID patient community. There have now been quite a number of studies of long COVID, and most of them report cognitive dysfunction of one kind or another as among the top 3 most commonly reported symptoms, particularly memory and concentration problems. So just to quickly recap on what I'm talking about when I say long COVID. Long COVID is, according to NICE, signs or symptoms that develop during or after acute COVID-19 infection, continue for more than 12 weeks, and are not explained by an alternative diagnosis. That's quite a nice definition. However, the signs and symptoms that qualify for this definition are never specified in the NICE guidelines. And we're beginning to see that long COVID is an extremely heterogeneous condition with a huge number of different symptoms. It also seems to be increasingly recognized as actually quite common. So the ONS figures suggest that around 21% of COVID patients still experience some symptoms at 5 weeks and around 10% at 12 weeks. However, again, this data is based on a list of 12 symptoms, and neurological and cognitive complaints aren't in that list. So it's very possible to believe that it might be more common than that if you were to include neurological and cognitive problems. Ongoing symptoms occur in around a third of non-hospitalized patients. And again, that's looking 2 to 6 weeks from disease onset. So it may be different further weeks down the line. And there's some studies suggest that as many as 25% still have persisting symptoms after 3 months. It seems that long COVID can occur regardless of the severity of the initial infection. However, there may be some association between those two things. It's difficult to tell because most studies that have been done on COVID so far have concentrated on hospitalised participants. And there's been much less research done in people who never went to hospital, particularly because early in the epidemic, testing wasn't available for people in the community. So people could have been really very ill, never gone to hospital, never got a test, and they wouldn't have been recorded in these kinds of figures. So what evidence do we have from the studies that have been done on long COVID that there are cognitive difficulties? In certain studies, such as Zayuddin et al. In 2021, just came out quite recently, they've done a really big study of over 2,000 participants, and they did quite an exhaustive list of symptoms. And here they found that the most common symptoms were exhaustion, with 72% of people reporting it, followed by cognitive dysfunction, with nearly 70% people reporting it. In around 37% of cases, at least one cognitive symptom was there from the beginning. But interestingly, in almost a third of cases, this was reported as a new symptom after the acute phase, suggesting that it wasn't a cognitive problem that developed early on and then just didn't go away, but was something that developed following infection. And actually, data from Davis et al. Gives us a really nice timeline of these sorts of events. Again, this was a really nice large sample of over 3,500 participants, and cognitive dysfunction was in the top 3 most commonly reported symptoms. If we look at the this timeline of symptoms, you can, and this is just breaking down into the cognitive symptoms, we can see that brain fog, memory issues, and speech and language issues actually increase with weeks since infection, and then stay relatively stable over around a period of around 6 months, which is where the study went up to. And we can see that in terms of cognitive problems reported in this study, there is a huge proportion of people reporting all different kinds of memory problems and speech and language problems. This seemed to be relatively independent of age. People across all age groups reported cognitive and memory problems, and speech and language issues occurred in around 50% of participants. So, and mostly this was in the form of difficulty finding words or whilst speaking or writing. Again, you look at 2 more studies, both of those again reporting that memory and concentration problems are one of the most common symptoms, and that those that don't go away after a period of time post-illness and sometimes increase with time. So, why does this matter? You know, in the face of people having, really, being in ICU, why does it matter if people have some problems with their memory and cognition? Well, it matters a lot because it's really, really impacting on people's ability to function. Around 86% of respondents in the Davis et al. Study indicated that cognitive dysfunction and memory impairment specifically was impacting on their work, on their ability to do their jobs, with around 30% reporting being severely unable to do their jobs. So it's not just jobs, these things impact on day-to-day functioning on a number of levels. So it really is a severe, long ongoing consequence of COVID infection that really needs us to address the underlying causes and to understand it more, because it's having a real effect on people. At the time I started looking into this, there were no studies looking at objective measures of cognitive impairment in COVID, but since then there's been quite a few. So the initial studies were mostly looking at patients coming out of ICU. And in patients coming out of severe medical intervention in ICU, it was found that 80% were showing indications of cognitive deficit as measured by the MOCA, particularly in memory, executive functions, and language. However, this data is limited to people who were really very severely ill. And it's already known that people who've spent a long time on a ventilator tend to show cognitive deficits afterwards that can last for quite some time. So these findings may not be specific to COVID. However, other studies using younger samples, such as Almeria and colleagues, only in that case, 20% of them who are in intensive care also report cognitive deficits. And a study by Helms et al. Showed that 33% of patients from their ICU study had dysexecutive syndrome, indicating frontal involvement. In a much, much bigger study, Hampshire et al. Used the Great British Intelligence Test participants to look at the impact of COVID on cognition. And this was much more representative of what we might see in the population, because they didn't specifically recruit people who'd been hospitalised for COVID, although they did include those in the sample because it was a very big sample. They managed to control for age, gender, education level, income, racial ethnic group, pre-existing conditions, and they found a direct association between the severity of initial illness and ongoing problems, particularly ongoing problems with word definitions and kind of verbal fluency. And in fact, so you can see here that it scales with the severity of initial illness, and these are the people that were on a ventilator, but there was even really very detectable cognitive deficits in those that never had any respiratory symptoms at all. The degree of decline in those that were on a ventilator was equivalent to the kind of decline you would see between the ages of 20 and 70 in a normal population. So we're really talking something quite severe. Okay, so I've gone over the literature why we might expect to see cognitive deficits following COVID. So what are the outstanding questions? Well, first of all, what is the nature of the cognitive impairment? I've shown you 4 studies, and there's a couple more out in the literature, but really there's been very little comprehensive investigation of what type of cognitive issues there are in COVID. Is this a general, cross-cognition problem, or are there any kind of specific deficits? I also wanted to look at what associations there are between the symptoms people report and cognitive outcomes. I've talked before that long COVID is very, very heterogeneous. There's a huge range of different symptoms people experience. And it may be that there's a number of different conditions people are experiencing that all come under this umbrella. And so one question was, is there a type of long COVID that is associated with cognitive deficits? And can we understand something about the mechanism through understanding which collections of symptoms lead to ongoing cognitive deficits? I also felt it was important to look at the association between the subjective experience of cognitive deficits, as we've seen repeatedly reported in the long COVID literature, and if you like, objective assessments of memory and cognition. This is important, I think, because patients have a real problem advocating for themselves with the medical professionals, because cognitive assessments are not something that's done in GP practices and in the clinic. And when they are, they tend to be things like the mini mental state, which really are very, very insensitive to the kinds of cognitive deficits that that younger working people might find have huge impact on their lives, but don't, for example, render them unable to look after themselves. What I'm not going to address today is one of the other, some of the other questions that motivated this research, such as, what is the timescale and form of recovery? And I'll mention that a little bit later on. Okay, so what did we do in the COVID and cognition study? This was an online study using Gorilla, which I highly recommend, by the way. And we recruited mostly on social media, but did a bit of supplementation with Prolific to get some demographics that we didn't otherwise kind of really recruit very well, mostly because the people in our social network profiles are quite a specific range of demographics generally. And this was designed, most of the questionnaires and so on were designed in consultation with the long COVID support group, who helped us a lot with like the list of symptoms and areas that we should look at particularly. And it took this form. So basically people gave their demographics, and we took quite a lot of demographic information, then some information about general health and previous conditions, information about experience of COVID, you know, have you had an infection? What makes you think so? Did you have a test? And a lot of stuff on symptoms. And then people did a number of cognitive tests. I'm not going to go through the kind of full study structure with you now, because today I'm really only presenting data from the initial session. And we've got quite a complex pattern of follow-ups, but literally none of that is relevant for today. Only to say that people who reported that they thought they had had COVID were included in our COVID group, regardless of whether or not they'd had a test. This was for a number of reasons, but mostly because at the time when most of our participants had COVID, testing was not available. So we would have lost a vast swathe of our sample, and also of the population as it exists. We did, however, take people who didn't think they'd had COVID, but had an illness that could have been COVID, and took them out of the sample entirely. So we can be relatively sure that everyone in our no COVID group had not had any illness that might have been COVID, which is not to say they might have not had an asymptomatic thing they didn't know about, but it's very difficult to do anything about that. The COVID group were followed up around every 6 to 18 weeks. And again, I'm not going to go into that. The no COVID group were regularly followed up to see if they'd caught COVID. So one of the initial aims of the study was to enable a kind of before-after infection comparison. But spoiler alert, nobody caught COVID. So we didn't do that. So I'm just going to go now through, just briefly, the cognitive tasks that we used. My research is mostly on memory, so I was particularly interested in looking at memory. So we used a word list recognition task and an associative memory task. And the associative memory task, you had 2 pictures, one food item and one item of stationery that were presented together repeatedly. And then at retrieval, you were presented with 1 item of stationery and then a selection of 9 items of food, where you had to choose which one had been presented previously with the item of stationery recognized. For executive functions, we used the Wisconsin card sort task, which involves matching cards according to a particular rule, but you're not told the rule. At some point, the rule will change, and you have to adapt your responding to deal with this changed rule. And this assesses kind of a number of executive functions, but particularly this idea of task switching. To assess visual working memory, we used a 2D mental rotation task. And then this was actually in response to reports of problems from the long COVID community. We also added a semantic memory sort of verbal fluency task in the form of a written category fluency task. I emphasize written because this is usually a verbally delivered task. But basically what it involves is you're given a category, so trees, for example, and then you're given 1 minute to write down as many examples of that category as you can. So we reported for this, for example, number of correct words, but particularly we were looking at errors. So repetitions, which would indicate forgetting that you'd already said something, but also kind of incorrect words, words that are not members of that category, and so on. And this was because this was a particular problem reported by the patient community. Okay, results. So huge number of health warnings here. This is hot off the SPSS press. Not final numbers, very preliminary. And importantly, prior to consultation with medical collaborators. I am an experimental psychologist, I'm not a medic. So I'm going to be throwing some medical terms around, possibly inappropriately. So apologies for that in advance. So first of all, our sample. Once we took out outliers and the people who might have had COVID, but probably not, we ended up with 185 people who had not had COVID and 181 people who had had COVID. The groups were broadly similar in sex, but in general, the no COVID group was slightly younger and slightly less well educated. And this is mostly because there were more university students in the no COVID group than in the COVID group. We recruited from a range of native English speaking countries, but the majority of our sample ended up being from the UK, with a slightly increased number of people in the COVID group from North America compared to the no COVID group. Okay, so what did we find? Well, the headline results was that we did find a difference between those that had contracted COVID and those that had not contracted COVID, particularly in word list memory. There was a significant difference in word list memory, but interestingly not in associative memory. And this is interesting because associative memory is generally thought to be harder, and it's generally where you see deficits in things like aging. So it was actually quite surprising to find a difference in the word list recognition, but not in associative memory. We also found a significant difference in the number of repetitions produced in the category fluency task, but not in any other kind of error and not in correct answers. Repetitions suggest, because if you can see here, they had this text box and they had to write, and eventually the words went off the end. So in a way, it's a little bit similar to having it presented verbally in that there is some memory of what you've already said involved because it's not all there in front of you, and a repetition suggests some kind of forgetting of what you've already said. We did find a difference in the Wisconsin card sort, but interestingly, this was in the other direction, that the trend suggested that people who had had COVID were slightly better on the Wisconsin card sort, but were significantly slower. It's important to note that the performance was non-significant, it was a trend, but the reaction time was really very significant. They were much, much slower. And I think that's slightly difficult to interpret, but I'll come back to that later. One of the things we really wanted to look at was how symptoms of COVID impact on cognitive function. So I'm going to divide the next sections into initial symptoms, ongoing symptoms, and current symptoms. So let's look at initial symptoms initially. So we asked people to report kind of just an overarching view on how severe their initial symptoms were. And what we got from our sample was that we had very, very, very few people who went to hospital or were in intensive care, and quite a lot of people who were very ill in bed at home, but didn't go to hospital. So we just reduced this data slightly so as to just look at asymptomatic or very, very mild, so sort of mild cold symptoms. Mild as in I felt quite ill and had to go to bed, but was fine. And then everything from I was extremely ill but didn't go to hospital up to ICU, because there were very few that went to hospital. What we found was that if you when we entered all the cognitive tasks together into a model, there was a significant association between initial symptom severity and cognitive task performance. And this was mostly driven by an association between symptom severity and word list task performance. We ran an extra model just really deep diving into all of the different factors, all of the different variables associated with word list. And it really was percent correct that was the association here, rather than there being a reaction time issue or anything like that. We also did another targeted investigation of the kind of second most significant cognitive task, which was 2D mental rotation. And again, when all of the variables associated with that were looked at just together, it was performance that was significantly associated with initial symptom severity rather than any other factor. So let's look at actual symptoms. We asked people about their experience of symptoms over 3 different time periods. First of all, asking about the initial symptoms during the first 3 weeks of illness. And this was the list of 36 symptoms, and they reported severe, mild, or not at all. We also asked about ongoing symptoms since then. So people were there was a big range of how many weeks since infection people were. So this was tried to get a general idea of how they've been since then. And then we asked about current symptoms, as in which of these symptoms have you experienced in the last 1 to 2 days? We then reduced these symptom reports by principal component analysis to try and get an idea of the sort of different groups of symptoms we're seeing in this population. So to look at initial symptoms, first of all, and again, I've got a health warning here because these are very preliminary labels. We extracted 5 initial factors. The first being mostly neurological symptoms, including altered consciousness, blurred vision, confusion, delirium, disorientation, and so on. The second one seemed to be more related to sort of systemic inflammation, including kind of rashes and welts on the skin. The third one I called classic COVID because we have loss of taste and smell, fever, cough, and so on. The fourth one was characterized by sort of gastric symptoms, whilst the fifth one was characterized by a sort of myalgia or malaise, a sort of fatigue, muscle body pains, chest tightness, drowsiness, limb weakness. So just to note, here are the kind of the top 3 symptoms each of these. So in the first one, it's very much the kind of delirium, disorientation. The second one is rashes, and so on. So what was the association between these initial symptoms and cognitive performance, sometimes many, many, many weeks later, sometimes more than 6 months later? First of all, looking at word list performance, we found a model, we used a stepwise regression, including all the symptom groups. And we found that a model containing only, a model containing myalgia and malaise and classic COVID was the best model for predicting the data. Both factors were relatively weak, but very significant. And we can see a significant reduction in word list performance as the severity of these types of symptoms increase. Sorry, stop. We can see a similar pattern emerging in 2D mental rotation with initial gastric symptoms. In terms of ongoing symptoms, we looked at people who had recovered from COVID, had ongoing symptoms, or who said it was too soon to say. So taking out the people who said it's too soon to say, we wanted to look at whether or not severity of ongoing symptoms was related to cognitive performance. And as you can see from this kind of weeks since infection plot, actually the majority of our sample were at least 6 months on from infection. So these are really long-term ongoing symptoms. So first of all, we found a directional association between severity of ongoing symptoms and memory performance for both wordless memory and associative memory. And wordless, but not associative memory, the effect was maintained after controlling for age. Again, in category fluency, we saw a significant increase in the number of repetitions. Again, that was the main thing, repetitions, increasing as severity of ongoing symptoms increased. And again, this was maintained even after controlling for age. Again, let's look at what the actual kind of range of symptoms looked like. And again, we had 5 factors, but these factors were different from the initial symptoms, which is what we expected, with kind of ongoing symptoms being a different form of symptoms than symptoms in the initial illness. Again, here I've highlighted the top 3 most fitted symptoms to these factors. The main kind of the factor that explained most of the data was something that I called multi-system with cognitive problems. This was mostly defined by the cognitive problems, but also included neurological problems and sort of malaise, body pains, limb weakness, fatigue, star problems. The second factor was more characterized by, again, kind of systemic inflammation / continued infection. So again, we've got rashes, skin issues, and kind of ongoing fever and things like that. The third one was very much characterized by neurological symptoms, potentially indicative of ischemia. The fourth one was more indicative of kind of loss of appetite, loss of weight, drowsiness, whilst the fifth one was indicative of ongoing mental illness, particularly anxiety and depression, and vivid dreams fitted into this one. So how do ongoing symptoms associate with cognition? Well, first of all, with word list, we found that a model containing the multi-systems with cognitive problems predicted a significant amount of variance. The more people reported, basically the more people reported cognitive problems, the less well they did on a test of verbal memory. Interestingly, Wisconsin card sort comes up here for the first time. And a model containing ongoing neurological problems predicted a significant amount of variance in performance on the Wisconsin card sort task. And this is interesting. I'll come back to it, but it's interesting because this is basically the one place that Wisconsin card sort comes up as a significant association. Okay, moving on to the symptoms that were experienced at the time that people were taking the cognitive tests. So remember that all the symptoms I've talked about so far were symptoms experienced in the initial infection or since then, but not on the day of test. We found, as you might expect, a significant association between how bad people said their symptoms were on that day and how they did, but actually, interestingly, only on the category fluency. There was no effect on any other cognitive task, which suggests that this ongoingness of the symptoms might be more predictive than how bad they felt that day. Again, we see this association with this kind of multi-system cognitive problems, symptoms factor and word list memory, here supplemented by an effect of this kind of loss of appetite, weight loss factor. And again, we see category fluency repetitions coming up as a significant outcome, and this time associated negatively with current experiences of mental illness. We wanted to have a little bit of a deep dive into current cognitive problems because that's really what we're interested in. Much like the previous literature, over 50% of our participants reported ongoing cognitive problems, with difficulty concentrating and brain fog being the top two, and forgetfulness being the third most common. Also, interestingly, tip of the tongue problems and semantic disfluency were also really, really common. And these are issues with coming up with words at all or coming up with the right words. People reported producing the wrong word when trying to speak or write. So the first question I wanted to look at just quickly was, do neurological symptoms early in the illness predict cognitive symptoms later on? And the answer was overwhelmingly yes. Almost every cognitive symptom was significantly predicted by this neurological factor of symptoms in the early illness. And again, remember, there's more than 6 months often between these two things. So that is an actually surprisingly strong effect. People who reported forgetfulness performed worse on memory tasks. Again, this might not be surprising, but it's important to note. And particularly this again was wordless memory, not associative memory. People who reported linguistic symptoms had problems with linguistic related things. So people who reported speech difficulty, so the kind of slurring of their speech as they tried to talk, had lower performance on word list and lower performance on category fluency. Similar sort of pattern with the tip of the tongue problems. So there does seem to be an association, as you might expect, between people's subjective experience of cognitive deficits and, if you like, objective measures of them in cognitive tasks. Okay, just to summarize the findings, COVID infection was associated with reduced verbal memory performance and repetitions in category fluency tasks. The initial symptom severity was associated with reduced cognition later on, particularly verbal memory and visual working memory. And the initial kind of classic COVID symptoms, if you like, along with a sort of myalgia, malaise, fatigue-related symptoms, were most associated with reduced verbal memory. Initial neurological symptoms predicted later cognitive symptoms. Nature of the ongoing symptoms were linked with the type of cognitive problem. Kind of multi-systems cognitive issues were linked with verbal memory, whereas neurological symptoms were linked with executive functions. The nature of the current symptoms linked with different cognitive problems as well. And again, you've got this multi-system cognitive problem associating with verbal memory, but it was mental illness symptoms that were associated with category naming ability. I'm realizing that I'm getting low on time, so I'll just quickly go through why I think this data is important. Well, first of all, it really, really matters for a very large number of people that are coming down with long COVID, that this really has an impact on their lives. I reported the impact on jobs in previous data, but in our data, for example, 38 reported long periods unable to work. 18 reported having lost their jobs due to ill health. 12% reported experiencing financial difficulty. 46% reported difficulty coping with day-to-day life. Is this related to cognitive problems? We foolishly did not directly ask that. Next time we will. Oops. But an initial sort of exploratory analysis suggested that yes, there was a direct association between wordless and category repetition performance and having had lost their job, and people who had lost their job due to illness. And actually that was significantly higher in people who had lost their job due to illness compared to people who had lost their job for other reasons during the pandemic. So that may be a real thing. It's important to understand the measurable cognitive changes underpinning subjective cognitive dysfunction in long COVID. Our data doesn't suggest a generalized cognitive impairment, but something relatively specific to verbal memory. The specificity relates back to the neuroscientific literature and clinical findings and suggests some form of temporal lobe involvement. And that's something that we can feed back into that literature. There seems to be a quite complex relationship between experienced symptoms and cognitive impairment. For example, executive functions didn't really come up much at all, except when looking at ongoing neurological problems, suggesting that there may be different kind of phenotypes, if you like, of cognitive issues, depending on the nature of systemic illness. Symptoms indicative of systemic inflammation didn't really emerge as predictive. However, there are different kind of manifestations of systemic inflammation, and something like Guillain-Barré syndrome might be much more kind of lined up with that sort of malaise, myalgia sort of symptom cluster. Whereas early neurological symptoms mostly weren't that predictive of the cognitive outcomes, but were predictive of the experienced cognitive symptoms. So there may be some sort of mediation going on. Importantly, people with long COVID are at real risk of what's called testimonial injustice. That is, that doctors don't believe them. 33% of our sample reported difficulties getting medical professionals to take their symptoms seriously. And that's mostly because these symptoms aren't measured in the clinic. They're not measured in the GP. And I'm just going to say the mini mental state doesn't count. Our data suggests that those reporting forgetfulness or linguistic issues have memory and linguistic problems that are objectively measurable. And that's something that is really important for patients to self-advocate. So very quickly, where are we going from here? We're following up on the participants. We've got NHS Ethics in to do a clinic-based study, and that's in collaboration with Muzaffar Kaiser. And hopefully all of this will be in a preprint really soon, so watch this space. Finally, I'd like to say a huge thanks to the team involved in this. This is an unfunded study that has basically been kept alive by an amazing team of students and volunteers. I particularly like to thank my PhD student, Pan, who has really been the kind of driving force of this. But Sabine, Alvaro, Lynn, Ruby, and Arca have been invaluable. So a thank you to them. Thank you to the Long COVID support group for their help, and to the rest of my lab for putting up with the COVID obsession that we've had for the last 6 months. Thank you very much.
Thank you, Lucy, for that comprehensive overview of an area of research that is becoming so important for so many in their recovery from COVID-19. Join us next week when we welcome Dr. Ewan Smith from the Department of Pharmacology, where he will give a talk entitled Bedside to Bench and Back Again, a Path to Translational Pain Research. Ewan is a reader and Deputy Head of Department at the Department of Pharmacology, while also being a Fellow of Corpus Christi College here in Cambridge. His research group focuses on understanding the molecular basis of nociception using mice, naked mole rats and human tissue, as well as investigating the cancer resistance and healthy aging of naked mole rats. For more info on this seminar series and all things neuro related here in Cambridge, follow us on Twitter at CamNeuro and follow the links below. See you next time.